Good morning. Okay. Thank you very much for inviting me here to present our early detection for delirium project, ED4D, which is one of the global digital exemplar projects that we're running at Salford Royal NHS Foundation Trust. My name is Niamh Collins, and I'm an emergency physician and clinical teaching fellow at Salford. And I'm presenting today, to be honest, on behalf of Dr. Emma Vardy, who's a consultant geriatrician, and she's the clinical dementia lead for the Salford Care Organisation and for the Greater Manchester and Eastern Cheshire Clinical Strategic Networks. So as we look at the poster and screensaver that we've used for this project, I'd just like to share with you some of my outline for this presentation. I will introduce the objectives of the study, briefly describe delirium and its impact on patients, their carers and clinicians, discuss the rationale for the project, identify and review the measurable outcomes, describe the methods and especially the digital components, and finally discuss our next steps. The aim of the ED4D project was to increase detection of delirium and to enhance detection of undiagnosed dementia cases in order to provide tailored care and improve outcomes. Being a global digital exemplar meant that we had the support of the best digital solutions to provide an evidence-based strategy ensuring best patient care. Delirium, also known as acute confusional state, is a state of mental confusion that can happen when you become medically unwell. It results in an altered level of consciousness, which may manifest as either agitated and distressed or sleepy and less alert. Medical problems such as infection and dehydration, surgery, medications can all cause delirium. It often starts suddenly and usually lifts only when the condition causing it gets better. It can be frightening, not only for patients, but also for those around them. Patients with delirium may be less aware of what's going on around them. They may be unsure of who they are, what they're doing there. They may be unable to follow a conversation or to speak clearly. They may have vivid dreams, which can often be frightening and may persist when they wake. They can hear noises and voices, even when there is nothing to cause them. They see people or things that aren't there, and they may worry that people are trying to harm them. They may be agitated or restless. They may be unable to sit still or keep wandering about. They may be very slow or sleepy. They may have moods that change quickly, become frightened, anxious, depressed, or irritable. We know that delirium is not well understood by healthcare professionals. It is poorly recognised and underdiagnosed. And up to 30% of cases of delirium are preventable. Evidence tells us that the detection of delirium improves care and outcomes, and we need to do more so that we can understand, recognise, and respond to patients who are at risk of developing delirium. Delirium affects approximately 1 in 8 acute hospital inpatients. In the emergency department, our prevalence is approximately 30% and often higher. We've never been more conscious of the financial constraints. Ballpark figures that an acute hospital admission costs £400 a night, intensive care £2,000, and it costs between £4,000 and £6,000 per hip fracture. We can see from this graph that delirium affects all areas and all wards in the hospital and has a significant financial impact. People with delirium are at a higher risk of falls and other harms. They have a 3-fold higher mortality. 1 in 5 die within a month. They are more likely to get dementia, and for those who have dementia, their rate of decline doubles. They have a 2 to 3-fold increased length of hospital stay, higher readmission rates, and are more likely to go into care. These figures have driven national drivers such as the National Early Warning Score, and the new News 2 includes "Is there acute confusion?" as one of the qualifiers. They prompted our Delirium and Dementia project and a desire to collect continuous data which will allow us to feed back to clinicians and drive change. At the first stage of our project, we identified outcomes that could be measured. Improved quality of care by increasing the percentage of over 65s who have a 4AT assessment done in the emergency department. improved quality of care by increasing the percentage of over 65s who have a 4AT assessment done on admission, reduction in readmissions within a month of discharge of patients with a diagnosis of delirium, reduced prescription of antipsychotic medications, improved mortality for patients with delirium, reduction in inpatient falls for patients with delirium, reduction in the average length of stay for patients with delirium recognised as either a health issue or a diagnosis, consistent adherence to comprehensive dementia assessment, and the FAIR assessment is a separate but linked process in keeping with the GDE ethos. We hope to increase dementia diagnostic rates for over 65s, leading to earlier treatment, enabling prolonged independence and a delay in institutionalisation. These outcomes were measured at the beginning of the study and now quarterly. A team was identified. It was very small in the beginning, but I'm really pleased to say that it is gathering momentum and growing. This diagram demonstrates our study design. The approach was threefold: digital, education, and leadership. The best available evidence was used to choose tools and help us to design a pathway. The 4AT was the screening tool that we chose. We chose it because it's a short, practical, validated tool which doesn't require any special training and can be used by both nursing and medical staff. It allows for assessment of untestable patients, so that's those who cannot undergo cognitive testing or interviewing because of their severe drowsiness or agitation. And it incorporates general cognitive screening to avoid the need for separate tools for delirium and other causes of cognitive impairment. It has a sensitivity of about 90% and a specificity of about 84%. Health Improvement Scotland shared with us their time bundle, which is a care bundle for the management of delirium. T, think about it. Think about possible triggers. I, investigate. M, manage. And E, engage. The time bundle is for completion by medical staff. And working with our IT colleagues as part of the GGE project, an electronic delirium and dementia assessment record was developed, incorporating both the 4AT and the time bundle. We liaised with clinicians to test the user-friendliness of the document and the accessibility of it within the electronic patient record. Digital training packages were developed to raise awareness amongst staff of the screening tool. We are indebted to patients and their carers who made personal contributions to this project. Their stories were collected to support training and education and to give us insights into what is the horror of delirium. Formal education sessions were introduced in the emergency department, and they have been subsequently incorporated into foundation training and at an undergraduate level. A team of delirium champions was developed, including carers, nurses at every level, doctors of every grade. We are cognizant of introducing another screening tool to patient assessment. However, delirium screening is supported by strong evidence and positive outcomes when implemented successfully. The role of the champions is to support ongoing training, enthusiasm, and a voice for cultural change with regards to delirium. Focusing on the technological aspect of the PDSA study, an email was sent to all clinicians introducing the 4AT in the emergency department. This was further supported by discussion at the safety huddle, which occurs twice daily at our nurse handover and brings up patient safety issues. The screensaver and poster, which I showed earlier, was developed to try and raise awareness and introduce this GDE project on the internet. An article was included in Siren, which is our trust newsletter. This is a screenshot of our delirium and dementia assessment tool. Clinicians can use tabs, on the left-hand side or across the top to navigate the tool. You might be able to see that there's a link to the diagnosis and management of delirium guidelines and also to the 4AT website. The first questions people are asked: does the patient appear to be confused? We've learned from this, though, and on our new emergency department documents, the delirium and dementia assessment tool will automatically open for patients over the age of 65, and this question about confusion will only persist for younger patients. On opening the 4AT screen, there are a number of questions to complete regarding alertness and information. If the score is 4 or above, then a red box appears. And this highlights that the patient has possible delirium and/or cognitive impairment. It prompts the nurses and doctors to ensure that the time bundle is completed within 2 hours. The final question asks whether you think the patient has delirium. If the answer is yes, a notice appears alerting the clinician to the fact that a health issue and a significant event will be created for delirium, highlighting the importance of recognising this acute condition. It also helps us to improve our formal coding for delirium, which further supports our dementia screening project. The time bundle has been modified for emergency physicians, and we call this the ED time bundle. Ideally, we would like emergency clinicians to complete all of the boxes and the answers to be yes. But if something isn't done or it's not assessed, then that information will become available to the admitting clinician or the next clinician who opens the delirium dementia document, so that they can be completed at that stage. You can see on the investigate box there's a link to submitting new orders, and in the explain box a link to submitting a new health issue if that hasn't already been done. We incorporated the order set to try and avoid clinicians having to leave this document and then order investigations separately. Within this order set, you just need to tick the box. In the emergency department, we use a bespoke electronic record, which at the time of introduction of the 4AT assessment didn't allow incorporation of this new format. Moreover, it sat within a mental capacity assessment part of the document. So recognising this and correcting it meant that we could make the screening tool more visible to emergency physicians. We are currently in the process of updating our ED documents as part of the GDE Emergency Department Transformation Project, and that will include both the delirium screen and ED time bundle. Having identified very low screening rates of the order of about 4% initially, a survey last year also revealed a very poor understanding of the importance of screening and management of delirium and of the digital solutions that we provided at Salford Royal. For this reason, 1-minute wonder posters were displayed in the toilets, staff room and in near-patient clinical testing rooms, and our thanks to Crosshouse Hospital for allowing us to use these. As discussed earlier, teaching sessions were delivered to doctors and nurses. We recognise the importance of digital solutions not only for the electronic document, but also to aid delivery of the training and education and leadership elements of this PDSA. A really active communication team supports the GDE project, and as part of this project, videos have been made and online learning packages being developed, which we hope to incorporate into mandatory training. We are exploring the use of virtual reality learning tools. We appreciate the role of social media to engage clinicians, patients and carers. For example, the development of a Twitter account and a medical student blog about delirium. Details of screening are being recorded electronically, and nurses and clinicians are being recognised for their screening rates and their positive influence towards change. Certificates will be presented by the champions, and this will be advertised on the Trust intranet. This project is supported by the executive body, and they are helping to raise the profile of delirium not only in Salford, but also spreading across Greater Manchester. I'd like to thank Sir David Dalton, James Sumner, Elaine Inglesby and John Rouse for their ongoing efforts. Now moving on to our results. This graph demonstrates improvements made in the percentage of patients screened for delirium since the introduction of the GDE project. The bold line in the centre represents the introduction of the electronic screening tool. Further improvements are noted with the introduction of training sessions, but we do notice a dip around the time of changeover of doctors, and that tells us the importance of ongoing education and the future introduction of online mandatory training. The fact that we are collecting this data on a daily basis now means that we are able to identify days where we have poor screening rates and work towards identifying solutions to improve these. Overall, the number of patients diagnosed with delirium, i.e. those with a coded diagnosis, is improving. This tells us that not only are clinicians more aware, but also that they are using the correct documents within the electronic patient record system so that we can capture the data. One of the aims of the study was to look at the impact of delirium screening on factors such as falls, mortality rate, readmission, and length of stay. As you can see from this table, there is a trend towards improvement. As this is the early stage of the project, we cannot draw any conclusions yet. We are aware that although there was an initial reduction in length of stay, this has subsequently increased. This may be multifactorial and we haven't looked into it yet, but it is planned in our next stage of the study. Our project has received national recognition. We have received an I Can Prevent Delirium Quality Improvement Award. We've been shortlisted for Quality Improvement of the Year HSJ Patient Safety Awards. A number of organisations across the country who are interested in doing something similar have been in contact. And that highlights to us the increasing awareness of the importance of delirium and the integral part that digital solutions play in the introduction of screening tools and management plans. Another facet of our project, as I mentioned earlier, has been the work with the communications team and the production of 2 short films, highlighting the importance of recognising delirium and describing it through the eyes of patients and their relatives. I would like Enid to tell us her story.
Being a global digital exemplar here at Salford means that we have the absolute best digital solutions for our clinicians and our patients, and that enables them to care for themselves or their patients to world-class standards.
So what we're doing with our Global Digital Exemplar programme is coming up with a...
I think we'll pass on through that, and I'll just go back and show you the links. Sorry, that is skipping too much, but the links to those films, if you'd like to have a look at them, are there. So what next? Our next steps are to continue to improve delirium screening in the emergency department and to introduce the use of the time bundle into our new document. We are currently rolling out screening to the emergency assessment unit, which is where the majority of our acutely unwell medical patients are admitted to. Ultimately, we hope to improve assessment throughout the Trust and throughout the Northern Care Alliance, culminating in the blueprinting of a template for delirium screening in cooperation with our GDE partners. This project has identified the importance of recognising delirium and treating it. We've used QI methodology and developed a bespoke electronic document that is accessible to all. It's resulted in a cultural change within the emergency department, which can be rolled out throughout the Trust and beyond. Thank you very much for listening to me today. I'd like finally to acknowledge these people and many more for their fantastic work and contribution to this project. Thank you. No questions.
Does anybody have any questions for Niamh? It's fascinating, and you see from the GDE perspective, we've got to get things like this codified and out across the country. It's wonderful that Salford's doing it, but we don't look so smart that nobody else is doing it. You come back to what Matthew was talking about. I just took your length of stay piece in there, and you just reinforced how long these people spend in hospital, and if we have an impact on that, obviously. It goes right to the capacity issue that Matthew was talking about at the heart of earlier this morning. So, but are there any questions for Niamh? Richard, you probably need to come up here.
So, that's fantastic work. I can see the amount of effort that's gone into that, and you're getting the benefits from it. But one of my concerns is that we are now having so many different assessments that we need to do when patients come in through the front door. We've got VTE, sepsis, delirium, and the list is growing, and the potential is that the junior doctors at the coalface are going to be confronted with page after page after page of stuff on the EPR to get through, and I think we all agree the value and the need for this, but I guess there's a piece of work that we need to do about trying to make it as smooth as possible to avoid duplication, but also how do we sell it? How do we convince the juniors? Because I've just tried to introduce VTE screening and they're all like, this is more stuff that we have to do. So we're trying to do sort of carrot and stick But it's a really big problem, and it's only going to grow. So, I'd be interested if you've got any thoughts on how you approach you sort of selling this to the.
So interestingly for us, our biggest challenge isn't our juniors as opposed to our senior colleagues. I think the fact that it started as a small team and that is snowballing into a bigger team, and the recognition that this is a phenomenally important condition. And there is a lot of crossover because it's caused by sepsis, MI, various other conditions. So actually mortality rates are really significant. And I think an understanding about that is really important. So what we're trying to do is, by means of the champions, by means of gathering information about what the reluctances are, where we can make a change, that's how we're trying to do it. And I'm very fortunate in that we have students who are doing quality improvement projects with us, and they're gathering this data. They're surveying clinicians, patients, carers, paramedics, nurses, porters, support workers. So we're going at it from a complete cultural change aspect, and introducing the teaching on a one-to-one basis, as you mentioned earlier, bringing this on the shop floor, rather than sort of, as they were talking earlier as well, about bringing patients to or clinicians to a classroom. We're trying to bring the information to patients as they're assessing them. But it's really difficult, and if anybody has any good ideas about how we could do it, I'd be delighted to hear them.
Thank you. Just to answer some of the questions, because I was helping Niamh to transfer our new documentation in Salford. And I think the carrot and stick is a very important part of this. And on one hand, as Niamh rightly said, our senior clinicians probably have more reluctant to introduce even more check boxes and pathways. But the fact that once, personally, when I was presented with the fact that this does improve mortality, that we can do things about it, because ultimately we're all trying to help the patient, and this was the selling point. On the other hand, the carrot in this one is that you can create automatic diagnosis of delirium. So a lot of, by ticking these boxes, it can help you with a lot of other things and can make things smooth. So the main thing is, rather than we provide the evidence how it can benefit the patient, but also trying to think in background the smoothest way we can integrate it and trying to put in as much carrot as possible for the clinicians.
And we're learning from their feedback, so when people say this doesn't work, we're adapting to try and make it more useful.
So at the back, Brian, lady at the back.
I'm interested to hear what you think the learning might be for other trusts who might not be GDEs and may not even have an EPR.
So I think that the combined effort, so I suppose the digital will be more of a challenge, but the combined effort of the education and the leadership, and perhaps a structured way, whether there's an ability. So what we used to do in the past when we were looking at different things was have a stamp box and take those things. So I think whatever works in people's individuals' trust, they know their clinicians and they're set up the best, and thinking about what might work best in that setting. But on its own, it doesn't work. I think the leadership and the education elements to it are hugely important. And I think adopting to what the clinicians are telling us and why this may or may not be working for them, I think makes a huge difference. But length of stay, I think for us as emergency physicians, when exit block has been really the focus of everything that we've been doing, when we can say this is what we can do to length of stay, that increases our flow hugely. So that's the one I'm going with at the moment. Oh yeah, and please do watch the video. I'm really sorry, we thought we had solved a problem, but there's the video, the engagement of patients and their carers telling their story of what it feels like to have delirium, I think has such a phenomenally useful effect. I can do, yeah, absolutely.
I'll try that.
Well, I couldn't embed it, this is the video. But we've... That works better, doesn't it?
Yeah, I think it's fine. Just
Being a global digital exemplar here at Salford.
That's great, I'll stop it. Yeah, that's okay.
Yep.
global digital exemplar here at Salford means that we have the absolute best digital solutions for our clinicians and our patients, and that enables them to care for themselves or their patients to world-class standards.
So what we're doing with our Global Digital Exemplar programme is coming up with a series of interrelated clinical projects whereby we look at the best clinical evidence and support these using digital technologies.
Patients are absolutely the focus of what we do here at Salford Royal, and we use digital technologies to help and enable them. Patients like Enid.
Well, I'd gone in my bed and I was just lay there, and then all the lights went out, and I must have been dozing off, and I began to look round, and I thought, I am wondering where I am here.
She asked me about a patient that was opposite her and the window, and she said, "There's something on the window." I said, "There's nothing on the window, Mum." I said, it was a drip stand and it was a saline bag. And I said, "No," I said, because Mum said it looked like a clown with a long face, and it was upsetting me more because I felt as though I wasn't getting through to her, and it wasn't my mum.
So we have introduced some bespoke electronic tools to be able to assess for delirium, but they also enable us to code for delirium, and that's been vital in terms of really understanding the prevalence of delirium in our acute hospital.
I keep saying I was never as frightened in my life.
So here at Salford we have the new delirium assessment tool, which is picked up really easy by us nurses. When doing the clinical observations, you can input that they have a new onset confusion, which will flag up to complete that assessment tool. The nurses will fill out that document and it will trigger to get a medic to come and assess this patient and see if this is a delirium, any underlying causes that may have contributed to it, and to then commence treatment.
So we spent a lot of time engaging with clinical leaders across the organisation to ensure that technology really is delivering for their patients.
Go on, Alex. Let me run it for 30 more seconds.
About 5 years ago, and we were one of the first emergency departments that became almost completely paperless, with all clinical nursing notes and prescribing becoming fully electronic.
I think the biggest impact as a team is the productivity. We're able to see more patients, we have more time to spend with patients and less time needed to be spent looking at a computer screen.
Thank you. Sorry, it didn't work.
So we got there finally. Are there any other questions before we wrap up for the morning? Thank you very much. Thank you.